Welcome to your fifth set of notes in the Unit 8 Clinical Psychology. Today we'll be talking about neurodevelopmental disorders. Neurodevelopmental disorders is a group of disorders that involve distortions in the development, which should be obvious since they're called neurodevelopment, so it's, in development. But you need to understand that this classification did not exist prior to the DSM-5, but in the DSM-5 they did add neurodevelopment into this because there is a genetic basis for these disorders. And these disorders are biologically altering because of something in utero or from the environment. They are basic psychological functions that are involved in social skills, language, perception, or motor behavior, and usually occur or diagnosed during infancy, childhood, or adolescence. Our first disorder that we are going to talk about is the Autism Spectrum disorder, also known as ASD. Typically shows an unusual pattern of social and cognitive development beginning in childhood with marked difficulties in social interaction and communication. This is a big indicator that it's autism, this difficulty in social interaction, action, and communication. So meaning they may have difficulty making eye contact. They have a difficulty communicating. They may do a lot of play by themselves and prefer that. And they also will typically not seek out comfort, especially from mom, which is unusual. The spectrum now includes from the highest to the lowest functioning individuals with characteristics of the disorder. With the DSM-5, this has expanded to include Asperger's. Typically Asperger's was separate, but now we have expanded it. The spectrum is now bigger. And so the autism spectrum disorder now encompasses all categories that used to exist separately from it. For instance, Asperger's syndrome and pervasive developmental disorder not otherwise specified. So when we talk about this disorder, it is a much bigger area because they've expanded and they've added in previously separated disorders. The new diagnostic criteria have been rearranged into two areas, either social communication interaction and restrictive and repetitive behavior. So when we look at characteristics, when we look at trying to diagnose someone with autism, they're going to be looking at their social communication and interaction and the restrictive and repetitive behaviors. For autism spectrum disorders, onset usually occurs before the age of 3, usually much earlier than that. Recent research has shown that if autism disorder is caught in quotes earlier, children show more success in treatment and more frequent in males, 4 to 5 times more likely in males than in females. And about 70% of autism spectrum disorders also have an intellectual disability. But you need to understand that it's not always present. The intellectual disability is not always present when it comes to autism spectrum disorders. And the reason for it not always to be there is because they have added in the Asperger's syndrome into the autism spectrum. So high in functioning on the spectrum tends to be Asperger's syndrome. ASD characteristics: impairment in social relationship. They show a noticeably lack of awareness of existence or feelings of others, and may not like to be touched or held. They might avoid eye contact and prefer solitary play. Impaired speech: about half of autistic children do not develop speech, and those that do develop speech often is like an echo of what is heard. So they will repeat a phrase that they have heard, they will repeat whatever they've heard in conversations around them. Sometimes they will be able to hear things once and be able to repeat the whole entire thing. Very narrow range of interests and activities. There's very much a fixation on something, and they may focus on objects almost obsessively. Like they might focus on trains or dinosaurs or unicorn. And sameness and routine are very important. Usually individuals who suffer from ASD, especially children, become distraught or angry if change occurs. Routine is very important to them. What occurs, especially in schools have to be very aware of which students are diagnosed with autism spectrum disorder, because they need to help those children be able to process when change occurs, because change happens and routines get disrupted from time to time. So typically schools will reach out to teachers of those students or an interventionist within the school that is working with that child to help them and give them a heads up. Most engage when they become distraught or angry like that in self-soothing behaviors to block out extra sensory info. They do not seem to have a way to block out the irrelevant information. They have no way to sift through that this is important and I need to focus on this, but this stuff is not, and I can sift out of it. It is all bombarding them and their brain is trying to take it all in. So they really don't have like selective attention. Their type of self-soothing they might do is they might rock back and forth. They might rub a spot on their body, like their hand or their arm or their leg. They might twist hair. They may need to have a certain toy to help them self-soothe. Causes of ASD, likely that both genetics and environment play a role in this disorder. Researchers have identified a number of genes associated with the disorder. And studies of people with ASD have found irregularities in several regions of the brain and abnormal levels of serotonin, which controls emotion and helps with sleep, and other neurotransmitters in the brain. So it's very much biologically linked, but there is a lot of research into what's causing ASD, but there's also a lot of controversy over what are the causes. And it is based on the research that they're finding. Now let's talk about the attention deficit hyperactivity disorder, also known as ADHD. This is the better known of the neurodevelopmental disorders. So you may have some knowledge of this already, but just make sure that when you are answering any FRQ questions that you are using appropriate terminology and not more common terminology. So this is a developmental disability involving short attention span, distractibility, and extreme difficulty in remaining inactive for a period. So these are individuals that cannot focus very well. The disorder estimated to affect some 3 to 5% of school-age children, and there are 3 subtypes. Not so much that you need to know the names of the subtypes, you need to understand the characteristics of the subtype. The inattention subtype can be easily distracted, miss details, forget things, and frequently switch from one activity to another. They have difficulty focusing on one thing. They cannot force their focus to occur. As much as they try, they cannot force themselves to stay focused on one thing. They become bored with a task after only a few minutes unless they are doing something enjoyable, have difficulty focusing attention on organizing and completing a task or learning something new, because it goes back to that lack of ability to focus, and then have trouble completing or turning in homework assignments, often losing things. They oftentimes don't have their homework, or they won't have a pencil, or they won't have the toy, and so they struggle to have the things needed to complete tasks or activities. Also with inattention, they not seem to listen when spoken to. It may look like they're listening, but they're really not. They are not focused on whatever is being said to them. They tend to daydream. They become easily confused and move slowly, and have difficulty processing information as quickly and accurately as others, and struggle to follow instructions. Because of these characteristics, they struggle to keep with the pace and are always seeming to be behind in getting anything accomplished. Hyperactivity subset is they fidget and squirm in their seats. They talk nonstop. They dash around, touching or playing with anything and everything in sight. They have trouble sitting still during dinner or school and story time. They want to be moving constantly. They have difficulty doing quiet tasks or activities. So hyperactivity subset is not only do they have trouble sitting still, but they also have trouble keeping their mind from being hyperactive as well. The impulsivity subset, these individuals can be very impatient. They blurt out inappropriate comments, definitely and almost always when they should not be blurted out. They show their emotions without restraint and act without regard for consequences because they know what the consequences are and they don't care, or they just think, it's not worth following and doing what it is to avoid that consequence. They often interrupt conversations or others' activities as well. which shows a lack of understanding that they should wait for the conversation to be finished. Causes, research does point to a combination of genetic and environmental factors, and treatment often involves administering stimulant drugs like Adderall, Ritalin, and Concerta. Now, you should have been immediately asking your question of why are they going to be administering a stimulant drug to someone who is already seeming to be stimulated? And it's because these drugs improve the symptoms of the disorder. They often have a calming effect. They may have some adverse side effects, but in minors, they tend to have the opposite effect. They tend to calm the individual down. Individuals with ADHD may have other disorders such as learning disability, oppositional defiant disorder, conduct disorder, anxiety disorders, depression, or bipolar. One disorder does not cause another, but the symptoms of one may make another more noticeable or severe, which just goes back to when we talked research, there's a correlation, and we all know correlation does not equal causation. We're now going to talk a couple of disorders that we have briefly mentioned in the personality set of notes a couple of lectures back. So make sure you go back to those notes and add these things in, or put a sticky note on top of them so that all of this information is together. These disorders have correlation to hyperactivity disorder. So oppositional defiant disorder, typically the behavior starts by age 8, but it may start as early as the preschool years. So we're talking ages 3 and 4. The symptoms must last for at least 6 months and be more than normal childhood misbehavior. All children misbehave. So now you have to look at it from the perspective of what is beyond normal. What is normal misbehavior and what is not? What becomes abnormal and therefore disordered? So actively does not follow adults' request. And once again, that is typical behavior for children to often not follow adults' request. So when does it become abnormal or beyond normal levels? They are angry and resentful of others, argues with adults, blames others for own mistakes, has few or no friends or has lost friends, is in constant trouble at school because once again they are not oftentimes following those adult requests. They lose their temper, they are spiteful or seek revenge, and are touchy or easily annoyed in temperament. The pattern of behaviors must be different from those of other children around the same age and developmental level. So there are acceptable behaviors that are seen as kind of defiant, that are misbehavior. So what is not acceptable for this age? The behavior is thought to be caused by a combination of biological, psychological, and social factors. So there's a lot going on within this disorder. Now, conduct disorder we have also briefly talked about back in the personality notes. So conduct disorder has been associated with child abuse, family conflict, genetic defects, poverty, parental drug addiction, or alcoholism. The diagnosis is more common among boys, and children with conduct disorder tend to be impulsive, difficult to control, and unconcerned about the feelings of others. They lack empathy, remorse, or guilt when they do something wrong. And remember, this was connected to antisocial personality disorder, but you cannot get that diagnosis until you're 18. So therefore you have to have the conduct disorder starting at 15 to then be able to get the label of antisocial personality disorder. Symptoms of conduct disorder, they're the antisocial behaviors. As I just said previously, this is not that they want to be alone, it's that they are doing things that are not socially acceptable, such as bullying and fighting, breaking rules without apparent reason. They don't care about the consequence. Cruel or aggressive behavior towards people and animals. So they get in a lot of fights, they use dangerous weapons, they are, forced sexual activity, mugging or purse snatching, destruction of property, deliberately setting fires, breaking and entering, destroying other people's property, heavy drinking and or heavy illicit drug use, because once again, these are things that are not deemed socially acceptable. Lying to get a favor or avoid obligations, running away, and truancy. beginning before the age of 13. They're skipping school with frequency before the age of 13, and vandalism. Children with conduct disorder may go on to develop personality disorders as adults, particularly antisocial personality disorder, as I've mentioned. If their behaviors worsens, these individuals may also develop significant drug and legal problems, potentially as a way to cope. Drug and legal problems also lead to that whole antisocial behavior. This wraps up your 5th set of notes in clinical psychology, neurodevelopmental disorder. If you have any questions, please let me know. Remember, don't do anything too stupid. Bye, guys.